Well, hello, everybody. Jackie Paige here, and welcome to another edition of Girl Talk Live. Today's Girl Talk Live hits very close to home for me. When I say close to home, like very, very close to home. And today we will be talking about women's gynecologic and intimate health with a focus on fibroids. If you're watching, I have a few questions for you. Do you have severe cramping during your periods or leading up to your periods? Do you have pain during sex? Do you have really heavy periods that just seem to last for days upon days? Is it endometriosis? Is it fibroids? Or is this something that you just have to deal with? We're going to talk about that all today. I have two very special people joining me today. They are so knowledgeable on this topic. First and foremost, I have Capital Region Health, Dr. Briana Walton, board certified urogynecologist and director of female pelvic medicine and board certified OBGYN. How are you doing today?
Thank you. Thank you. I'm doing great. Great to be here.
Glad to have you. And then also joining, we have Doctor of Minimally Invasive Gynecologic Surgery, Dr. O. Lawrence Stitt III.
Hey, Jackie, what's going on? Thanks for having us. We're happy to be here today.
And like I said, this topic hits very close to home. For me personally, I will just go ahead and be completely open. Both my mother and my grandmother have dealt with fibroids, and it is something that just seeing my mother go through that experience a few years ago, I'm gonna be honest, I'm scared. I've had a best friend that went through it a few years ago, so I've seen it happen, and I've seen women very close to me have to deal with this. So, like I said, I'm nervous. I'm scared for my own health, for those women around me, their health. So, like I said, I'm really happy to have you guys on to really talk about this. One, to just help ease my nerves, but then also to ease a lot of the nerves of the women and men that may be watching. So, with that being said, let's go ahead and just dive right into it. What are fibroid tumors?
I'll go ahead and start, Jackie. Fibroid tumors are tumors of the womb, plain and simple. They occur in the uterus, that is that organ that the babies come from. In most cases, they're benign, meaning they're not cancerous, but they are tumors. And it's important to make that statement because a lot of the times we talk about fibroids and there's just these things that make life difficult, but they really are tumors, something that should be followed up, evaluated periodically. But not the malignant kind, not the kind that are going to spread through your body and cause cancer and cause everyone to be concerned and worried about your life expectancy, but they can make life tough.
How do you know if you have fibroids? I think about like my mom's situation, and I didn't know she had fibroids until maybe like a week or so leading up to her having surgery. So how is that something that you know that you have?
If you don't mind, I'd like to take it because, this topic also hits close to home as a person who has had both fibroids and endometriosis. So I've been on kind of both sides of the fence, and I didn't know. And I was an OBGYN. I just knew that I had extremely painful periods. Even from the time I was 12 years old, it was just like every year it was not getting better. It was, in fact, getting worse. A lot of women complain of extremely heavy periods. Or they're bleeding in between. And that can be really bothersome because then it becomes less predictable and you can't manage it as well. I think one of the more troublesome symptoms is when you don't know what's going on and you start to have pain with sex, like you talked about. And it tends to be more with a deeper penetration. But again, most women don't really know what's going on. They just know it doesn't feel good. And they're afraid to say something to their partners. They're afraid to say something to their doctor sometimes because they think, what is probably just me.
Mm-hmm. Now, is it will a woman experience all symptoms, just maybe one symptom? Like, what does that look like?
She can experience one or she can experience many. Really, it just depends on the location. It depends on the size. It depends on how long she's had the fibroids. It depends on, and that actually has more to do with some of the fibroids after you get older will start to get denser and thicker with calcium deposits. And so they cause more compression. So in my world, I often see postmenopausal patients who have fibroids, and that fibroid is pushing up against their bladder or pushing against their bowel. And so even constipation or urinary symptoms are common.
Is there a particular age? Like I said, I had a best friend that had fibroids, and I think she was like 24 at the time. My mom, I think she was pushing 50, maybe 51. So is there like a particular age? Because I've seen both ends of the spectrum.
I'll take that one, Jackie. That's hard to determine. It's a question that's hard to answer because fibroids grow at different rates. So I heard you mention your family history. And one of the things that I talk to my patients about is what has happened to other women in your family. I had patients that come in with large fibroids, right? And they had been there for a while. They've just been undiagnosed. So I asked, tell me about your mom's menstrual cycle. Well, she had to have a hysterectomy because of fibroids. I have fibroids. And then I asked, do you have any children? I often hear, yes, I have a daughter. I said, well, tell me about her menstrual cycle. Well, it's just like all of ours. Ding, ding, ding. It may be that she has very small fibroids that are now starting to become symptomatic. So these can happen as early as at the time puberty begins, or we can actually start seeing them start growing and developing more in the later ages, 30, 40, even late 40s. It just depends on early identification and reducing the risk factors that cause them to grow, which are many. I mean, studies have shown that the more babies you have, the fewer fibroids you're going to have. I mean, fibroids are related to the hormones that are released from the ovaries. And when you're pregnant, you don't have a cycle. So those hormones aren't being released that way and the fibroids aren't growing. But the patients that I see who have had one child compared to the ones that have had 4 or 5 children and both have fibroids, there's a vast difference in the size and the symptoms.
So, and correct me if I'm wrong, I'm hearing that fibroids are hereditary, correct?
Yes. That, there's been a lot of research done on women and the incidence of fibroids. And what we found is that probably 80% of women from the African diaspora will have fibroids by the time they turn 50 years old, period. If that's where you're from, 8 out of 10 women will have fibroids. Only about 35 or 40% will be symptomatic, but about 80% will have fibroids. Where if we look at the white population, about 70%. So there is definitely an increased incidence in fibroids if you're from the African diaspora.
I want to go back though, because Dr. Stitt brought up a really great point about if you have daughters, and a lot of times we just say, well, that's just what it's like for the women in our family. And that's really one of the problems. Mm-hmm. We don't want to propagate the myth here is that it doesn't have to be that way in your family. And so we want to be able to talk about, well, what does early intervention look like? And it doesn't necessarily have to be surgery.
So speaking of early intervention, we've clearly established that this is something that's hereditary. Like I said, my grandmother has dealt with it. My mom has dealt with it. I, at this point, haven't experienced any symptoms. What are some early things that I can do? 1, to find out if I have them, and then 2, to make sure that, if they are small, that they stay small, that they don't get bigger. Like, what are things that I can do?
Generally, when you're going in for your routine examinations, if we're able to take our hands and put it around the uterus and try to palpate and feel, we can tell if there are fibroids there. If there are limitations to that exam where we can't really compress and squeeze and feel what's inside, if there's symptoms, we will often order an ultrasound. That will allow us to sort of see the size and shape of the uterus and if there's a presence of fibroids.
I'll add a little bit to that too, Jackie. So, sometimes I have patients that come in, and because this is what I focus on, the first thing I ask is, tell me about your menstrual cycle. Can you go to work? Do you have to stay home? Do you have to wear particular clothes? Do you have to wear diapers when you go to sleep so you won't soil your sheets? Sometimes these are things that I see patients do, and they just think that, well, that's just the way it is for me. I can't go to work because I'm tired, I'm weak. I can't have sex with my boyfriend because I'm always bleeding. But the actual fact is that there are likely some fibroids there that need to be taken care of. And that's when we intervene and we start ordering these tests. But it takes 2 things. It takes 1, it takes a provider that's interested and cares. And it takes 2, someone comfortable enough to talk about this and willing to do something about it.
Absolutely.
Question, going back to the symptoms real quick. Is this, are the symptoms something that they happen month after month after month and time after time? Or is it just like, hey, it may happen this month and then maybe 6 months from now, like I'm experiencing a heavy period again? Like, Is it a constant thing? Is it a every so often thing?
Generally, we see a progression over time because as you make hormone, you're feeding the fibroid, so to speak. And as that you're feeded, it tends to grow bigger. And so it tends to be more symptomatic. So we do usually see progression, but it doesn't have to be every single month. You might have a month where it's fine. You didn't notice any symptoms at all. And I know you had mentioned endometriosis in the introduction. So is the pain that a patient's having or the symptoms that they're describing, is it the fibroid or is it endometriosis? And that's another thing that we want to try to figure out so that we can treat it appropriately.
Got you. Do the symptoms get worse as you get older? Is it like, oh, I'm fine at the age of 25 and then 30? Because again, in complete open and honesty, I will say my menstrual cycle at 25 is completely different than my menstrual cycle now. Yeah. So, is that something, and I'm being completely open and honest here because like I said, this is something that hits close to home. Is that something that I need to be mindful of?
So, your menstrual cycle at 15 is going to be different than it was at 25, and it's going to be different at 35, 45, and 55. As your ability to produce these hormones changes, the cycle will change. However, when we talk about, and I have to keep going back to this, Jackie, when we talk about tumors are growths that grow out of control faster than they're supposed to compared to other tissue. And over time, they will continue to grow. So, for example, a lot of patients that I see, I refer to Dr. Walton because of urinary incontinence, right? Mm-hmm. These tumors can grow in an area right next to the bladder. If they're small, the size of the pea, they may not push on the bladder much. But if they become large, the size of a grapefruit, what they'll do is push on the bladder. So every time somebody goes to jump up and down or exercise, they're leaking urine. So over time, they can start as a pea, but as you get older, they can become larger. And what Dr. Walton mentioned before is that once you get to a certain age, you get to that golden age where the bleeding goes away, right? The growth of the fibroid actually ceases and they become calcified. They shrink some, probably 10, 15%, but the symptoms resolve. So over time, they will kind of get better, but between puberty and menopause, it can be a tough time.
I'm just laughing because a lot of times patients think once they go through menopause, they're going to get rid of their pads. And then they start having urinary issues and they're wearing pads again. So it can be very frustrating.
Yeah. Is this a conversation? Like I said, I haven't experienced any symptoms, but knowing that it is something that is a part of my family history, is this something that I need to talk to my doctor about just to put her on the radar?
Mm-hmm.
It's funny that you bring that up. So we often think about fibroids as something, let's wait until symptoms occur. Let's wait until you have an obstetrics, we say 4 miscarriages, which is ridiculous. But at that point, they become a problem. Let's wait until you bleed more than you should, and you have to stay home at work. What would happen if you went to the emergency room and your blood pressure was 170 over 110? They wouldn't say, let's wait until you have a stroke before we give you medication. They would treat you right then and there. So your question is very valid. What should you do? You should be diagnosed and followed conservatively with ultrasounds to evaluate the growth. You may not need any intervention. However, if the fibroids start growing rapidly, there's things that can be done non-surgically to slow down the growth, such that you may not have to have that hysterectomy at 45. You may not have to suffer from miscarriages and preterm labor and delivery. I recently was on call one day and a young lady came in, 21 years old, 10 centimeter fibroid, 24 weeks in labor, and she delivered prematurely. And that's a story that I just would not like to see ever again. It's something that's preventable. But I think if you know you have them, they should be followed conservatively.
And with your family history, Jackie, one of the things we talk about, and I know you know this because of your background and what you do, but diet. We know that a plant-based diet and low hormones are better for a patient who has a risk factor for fibroids or the presence of them, that it can actually cause it to shrink or not grow.
What are some other things that I can do to prevent I don't know if there's anything that I don't even know if there's really a way that I can say like prevent it or just like keep them small, but what are some other things that I can do as far as fibroids go? Because I kid you not, like I just think about the pain that my mother went through, and that's just something like after she had the surgery and after she like revealed to the family that she had fibroids, like I saw the telltale signs, but I didn't realize it until it was until she like opened up and said something about it. But I just think about those signs and I just keep thinking like, I don't want to experience that because it was a lot for her.
You know what can you do if you're diagnosed with fibroids early on? And that is a wonderful question. Definitely not surgery. What I hear often from patients who come in with very small fibroids is, Doc, I'm here for my hysterectomy. Why? Right. Well, because I was told that I need to have one because I have fibroids. Why? Well, because I have heavy bleeding and I can't go to work and it hurts and it's interfering with my life. Well, why do you have to take out your womb? Why do you have to castrate yourself? You're only 26, 27 years old. So there are things that can be done. One, we talked about diet, keeping a nice, healthy diet. There have been studies that have been done recently that show that if you increase your fruit and vegetable intake by at least 2 fruits, 4 vegetables per day, you can reduce the growth of your uterine fibroids. Also, we now have medications, hallelujah, praise him, that we can give patients to treat fibroids so that we don't have to do surgery. We can slow down the growth. Even if we can shrink them. There are medications we can use to shrink the fibroids by 65, 70% once they start growing. So there are so many options available now. Gone are the days when you have to have your mama's hysterectomy. And I'm not saying that specifically for you. I'm saying that's what patients tell me. I need to come to have hysterectomy because my mama had one. Well, not necessarily. We need to watch things, educate you on diet, make sure you stay away from some of the risk factors like obesity, and that can overall, I think, decrease the growth and keep your fibroids manageable. The key is managing, not necessarily removing organs, but managing fibroids. There's nothing that we can do to take them out. I tell patients the same thing that causes you to have fibroids is the same thing that gives you the skin color that you have. You can't change it. They're going to be there, but we got to manage it as best we can.
Question, once you've been diagnosed and you find out that you do have fibroids, let's say that you do get them removed, or let's say you do get them removed, you decide to do a hysterectomy. Is there a potential, is there a possibility that they could come back?
Well, once the uterus is completely gone, there's no chance that is going to recur. The only time that happens is if there was a fibroid that was left inside, or it was growing from another source that we didn't see. That's very rare for that to happen. But as long as you remove the entire uterus, there's really no chance that it's going to come back again.
I will say, to add on to that, is that if you do have these fibroids, you have some surgical intervention, right? So sometimes I have young patients who come in 29 years old with these fibroids. And they say, Doc, I need to have this fibroid taken out because I'm going to have a baby. And it's interfering with my ability to have a baby. Right. Okay, fine. We'll take them out. Cool. Come in. We'll schedule your appointment. We'll take the fibroid out. We take the fibroid out of a 29, 30-year-old patient. As I mentioned before, it is the menstrual cycles and the estrogen and progesterone released from those ovaries that cause a fibroid to grow. So I can go in and I can remove every fibroid that I see. But if there's a microscopic cell that's going to become a fibroid in 10 or 15 years, I wouldn't see that. So there is some likelihood of recurrence. And I tell everyone that has a likelihood of 5 to 7 menstrual cycles or 5 to 7 years of having menstrual cycles, that is a small recurrence risk that it could come back.
So just to clarify, a myomectomy is removing the fibroid itself. A hysterectomy is to remove the entire uterus or a portion of it, not the ovaries and the tubes, the uterus.
So while we're here, let's talk about because I know this is a question that a lot of women have. We have the myomectomy, we have the hysterectomy. I've seen a hysterectomy process, and I know the recovery time. Well, I haven't like physically seen it, but I've seen 2 people go through it, and that recovery process was a lot.
Well, it all depends on what kind, right? So there are different varieties.
So please educate me and everybody watching. Let's talk about myomectomy and the different types of hysterectomies, and then also like the recovery time for those.
All right. So I happen to specialize in minimally invasive surgery, meaning I do the least amount of surgery that's required to get the problem done, period. So when we talk about procedures to treat fibroids, I'm going to talk about myomectomies and hysterectomies, but I like to start focusing on just the fibroid. There are procedures that we can do to decrease the symptoms of the fibroid without removing anything. You can come into the hospital, I can perform a procedure in 30 minutes, you go home, go to sleep, wake up next day, go to work, and no issues. Fibroid symptoms decrease, bleeding decreases, pain decreases, life goes back to normal. Now, we don't remove the fibroid. That particular fibroid won't cause any problems before, but if they recur in the future, that may. We talked a little bit about that. Now, let's talk about minimally invasive types of procedures that require incisions, right? So there's some that are called laparoscopic. Those are the ones where we use these little instruments and we do these little, make these incisions on the belly that are about this big, and we do the hysterectomy or myomectomy, which Dr. Walton mentioned, removing the fibroids from the womb. And we perform that procedure. You go home. Recovery time has been, I've seen anywhere from 3 days to 3 weeks for that type of procedure. So that is minimally invasive, least amount of surgery in a way such that you can recover. So for moms that have to take care of their kids, that are single moms and they need to be active. The first patient I ever did this procedure on was a patient who had 3 boys. And she told me, she said, "Doc, I got to go home, got to wash clothes, got to cook for these boys. So do whatever you got to do, but I cannot be sitting up for a long period of time." I said, "Okay, well, listen, you're going to sit up for 3 days at least." She said, "Okay, fine." So she listened to me. She did what I asked her to do, and she was good to go. She was able to do that. So that's minimally invasive surgery. And that's something that I think a lot of folks can benefit from. And I'm glad we have it here in Cap Region. Next is the abdominal surgery. That's the one where we do the bikini cut. That's the one that we tend to call your mama's hysterectomy. And that's the one that is more commonly done. And that one is one where, yeah, Jackie, that one you're going to maybe be in the hospital for 3 days, maybe 4 in some cases. That's where your recovery is going to be 4 to 6 weeks. And that's where you're going to be in pain. You're not going to want to move. You're going to be in the bed, and life is just awful for that period of time.
Yeah, you're walking bent over. You can hardly stand up. You feel tired all the time. So we really try to avoid those kinds of surgeries. One of the things that's come up more often in the last 10 years is our ability to do it with robotic surgery, which is one of the things we want to talk about as we, I know we're going to run out of time here today, but using an instrument where we, instead of standing over you, we sit behind a console and we control the arms of the robot to actually do the procedure. We could be in another room. We could be in another state and actually do this kind of surgery. So it does help with our ability to move our hands, to magnify things so that we can capture blood vessels. So what we find is that there's less bleeding during the surgery, there's a quicker recovery, and we, generally speaking, patients, I will say from my own personal experience, undergoing a robotic hysterectomy, that 3 days afterwards, I was sitting at my table having a business meeting like I never had surgery.
Oh, that's, I mean, again, from what I experienced with my mother, it's good to know that there are some other options, because honestly, the only thing I knew was everything has to go. You're going to be bent over. You're going to be in the hospital for a few days, maybe even a week. I just remember her saying it felt worse. And I'm one of 3. She said it was worse than having kids.
Wow.
And yeah. And, just hearing that and hearing her say that, and that's part of the reason why, this is scary for me, because I'm like, I just don't want to have to go through this. And if I do have to go through it, what are my other options? Because just hearing her say that, you had 3 kids and you're saying that this hurt worse. I don't
that's why we're here at Cap Region. We wanted to bring our skills to patients that weren't getting access to this kinds of therapy. It just, you were finding it in certain places and spaces, but not universally. So that's our hope, is that we're able to make a big change for our institution and our community to be able to get what they need when they need it.
Yeah. I mean, education is huge. And when I tell you I'm learning a lot right now, I literally am learning a lot. My nerves went from here to about right here now. I'm sure by the end of this, they'll be down here. But no, that's it. It's really like, it's one of those things. It's, it's a part of my family. So there is a chance that it will happen. But to know that the option for me doesn't necessarily have to be having everything removed and having all that pain. Like that really does give me a lot of peace, because that is what I know of fibroids is it is a very painful experience. And I just don't, I feel like my pain tolerance is pretty low. It's just something I don't want to have to experience. So the education piece is huge, not only for the people that are watching, but also me, because like I said, this is something that is very near and dear to me, and it hits very close to home. Question: fibroids, endometriosis. What's the difference between the two?
Interesting.
So we talked about fibroids, and we talked about the relationship to being tumors that grow, that cause significant pain and bleeding and problems with fertility and pregnancy. Endometriosis does the same thing, believe it or not. The difference is we're not talking about tumors. We're talking about something a little bit smaller, and these are just cells. Now, it's interesting. We don't know how they get to where they get to. We find them inside the abdomen. We find them attached to bowel, attached to bladder, everywhere. One of the theories is that when you have your menstrual cycle, some of the blood goes back through the fallopian tubes into the abdomen and sticks there. And every time those cells, or that blood that contains some cells, gets exposed to estrogen, it starts squeezing. Let's use that analogy. It starts squeezing and growing and squeezing inside the abdomen. It causes significant pain. It can be more debilitating than fibroids. The pain can be so severe that you can't walk. It can be so severe that you must stay home for weeks on end, because once there's a flare that occurs, you can't do anything about it. Some of the common symptoms that we see within endometriosis are pain during your menstrual cycle, pain before your menstrual, pain after, pain during intercourse, pain during bowel movements. I mean, those are some of the telltale signs that you need to be evaluated, but it can be pretty debilitating.
And I think that the key word here is pain. We see more pain issues with endometriosis, but sometimes you can have endometriosis and not have any symptoms. It's silently occurring, but causing scar tissue and causing the organs to go into a position or hold in a position where we don't want them to. It's very interesting on the surgical side, and we both can account for this. Sometimes removing endometriosis or trying to do surgery in someone who has endometriosis can be more challenging than someone who has cancer. Wow. Because it doesn't tend to stay in one place. It can invade in the wall and through the wall of surrounding organs. So some women will even have problems with blood in their bowels from endometriosis, or blood in their urine from it. It is one of those things that it does require us to be suspicious and then investigate usually by surgery, in order to figure it out.
Can I share the good news?
Yeah.
We got medication. Technology is advancing every single day. And for that type of endometriosis, that's not the type that causes organs to stick together, that prevents you from becoming pregnant, that causes blood in your stool or your bladder. There are medications that can be taken that don't have crazy side effects, that don't have any long-term negative effect on your body, that can really decrease the amount of pain and allow you to have a better quality of life.
Is endometriosis hereditary? Because I know we talked about fibroids being that way, but is that the same with endometriosis?
It's very common for patients to have a family history of it. Does it follow the same sort of hereditary pattern? That's harder to say. But it is something, again, if your family members have been plagued with it, that should raise our suspicion that you might have it if you have symptoms that are associated with it.
Does having endometriosis or having fibroids put me at a greater risk of having ovarian cancer?
No. So let's talk about this. So ovarian cancer basically can have multiple types. Ovarian cancer is probably a banner that we should say, and there are different types of ovarian cancer that fall under it. Some are more associated with potentially getting to cells from the tubes. Others come from the germ cells, the ones that are responsible for us making babies. Others come from the structural areas. So the presence of fibroids doesn't change it at all. Endometriosis, having sort of abnormal tissue, doesn't change it, but it makes it harder to feel it sometimes just because things are scarred into place.
Okay.
I'd like to add something, Jackie, just before we switch topics, because breast cancer is important in our ovarian and breast.
Mm-hmm.
They work together by very similar mechanism. And it's just, if there's anyone in the family who has breast or ovarian cancer, an aunt, a grandmother, a sister, anyone, the patient should be evaluated. There is a significant genetic predisposition to ovarian and breast cancer if someone in the family has it. So sometimes this conversation isn't had with patients, and it's important to share that. So when you brought up ovarian cancer, I just felt the need to put that plug in that if anybody in the family has had ovarian cancer, you need to have your genes checked, because if you do, there's a chance that your life expectancy can be extended by 15 to 20 years if we intervene.
Right.
That's all. I'm sorry.
That's a great
point. No, that's a very good, very, very good point. And this is a little random question, but I just feel like it's important to ask. We talked about earlier, if somebody in your family has fibroids or endometriosis, it's something that you kind of want to like figure out and find out, know how you stand. Like I said, I didn't find out until a week before my mom had it. And then that's when my grandmother wanted to come out and say, oh yeah, I had it too. Any advice for women who may be in the situation of like, I think this may be something that's hereditary in my family. Like, how do you have this conversation? Because when it comes to health, that's something that's very taboo in the Black community. We don't want to have those conversations. So what advice would you give to the Black community in particularly, especially Black women, as far as like having these conversations with like our moms, our aunts, our grandmothers, our great grandmothers, because it's something that unless it's about to happen, we don't talk about.
You bring up a great point. And I do think it does track a little bit by age, right? Like my mom won't have certain conversations that I will have, but I probably won't have certain conversations that younger people do have. So I think as we've gotten younger, or as a population has gotten younger, they do talk about these things a little more. And social media has helped to sort of get information out there. But what we want to do is get the right information, and we want to get the right information to the right person. If you're asking a girlfriend about your medical issues, she doesn't know your medical history. She can only tell you about what happened to her or what happened to her family member. So it really is imperative for you to go back to your own provider, talk to your doctor who knows your family history, who knows your history in general, so that they can help you make some decisions about how do we prevent, how do we treat, how do we move forward.
Yeah, great points. Talking about girlfriends, I actually had and I mentioned this earlier, I had a best friend who had fibroids. She had them removed, and she was actually told that she couldn't have kids, but ended up getting pregnant. So how does having fibroids affect pregnancy, getting pregnant, and then also like if you have fibroids and you are pregnant, how does that affect that?
So fibroids come in several types, right? There's some that grow on the outside of the womb. Like I use the analogy of a tree growing off of like your backyard. There's some that grow in the inside of the womb where a baby would be. If there are large fibroids that grow inside the womb, it's very difficult for the baby to grow and the fibroid to be present at the same time. So that can sometimes end up with the fibroid winning the fight and a miscarriage or a preterm delivery. In cases where the fibroid is on the outside of the womb, it can hang out there as long as the pregnancy continues. It can often cause significant pain during the pregnancy in different parts of the abdomen, left, right, upper side, and that can be treated. And then there's the fibroid that is not on the outside, not in the inside, but in the middle. And it's those that are most concerning for pregnancy, because what they do is they prevent the baby from turning around and doing all the normal stuff that babies do inside. They like to play, they like to have fun, they like to swim, they do all this cool stuff inside the womb, but they can't flip to the right side to be head down. And they subsequently have to be removed surgically. So that's a C-section, right? Yeah, it's a C-section. It's the most common procedure that women have in the United States today. But if there's a fibroid tumor there, that can lead to significant bleeding, significant problems, and sometimes hysterectomy. So fibroids
emergently.
Yes. So not, the next week, right then and there when there's a significant amount of hemorrhage. So fibroids have many different effects on pregnancy, and there's still some pregnancies that continue without any complications. So I don't want to give the message that if you have fibroids, you become pregnant, you're doomed, you're going to have a complication. It's just that you need to be followed closely by someone who knows how to manage pregnancies with fibroids, usually a maternal fetal medicine specialist. We have one at UNCAP region who specializes in following patients with fibroids. And you can have a pregnancy that goes to full term. It's just we have to be very careful on how we manage it.
And our maternal fetal medicine provider is also an expert in making sure that the cervix doesn't dilate early, or monitoring that when you have the complications associated with fibroids. So again, you have to have, you said in the beginning, you need somebody that cares. You need somebody that's listening and that they understand your history. And that's we're trying to say, get to your doc, make sure they understand what's going on, and make sure they understand your concerns, and get your questions answered.
Yeah, I think that's so important. You have to have somebody that cares. And I think one of the things that we don't do enough of is being adamant about what's going on with us and what we need. I think we kind of just like say, oh, this is what the issue is. And we let somebody say something and that's the end of it. Yes. This is our body, our life, and we have to do a better job. And I'll say I'll fall victim of it too. I'm not going to say I'm the best person at it, but we, speaking to myself, we have to do a better job of just.
And quite honestly, I know with COVID, we've limited the number of people that have come into the office. But if you want to bring a friend, if you want to bring a family member to a visit, it's okay for you to do. And they can speak up and ask questions that maybe you're afraid to.
I do it all the time. I love when I see partners come in with the patients, because I'll ask the patient 10 questions and they'll give me all the answers. Now I turn to the partner and say, now tell me what's really going on. And then they tell me everything that I need to know that the patient didn't want to really feel comfortable talking about, but she had been talking to the partner about it for weeks, for months, for years in some cases. And the partner is there because they care and they want their partner to get some help. So it's important to have someone with at times.
Yeah. Being somebody who, like I said, it's hereditary, it's in my family. I've come to that acceptance at this point. I haven't had any issues to date, and we're going to hands up and pray that I don't have any issues. What are things that I can do to make sure that, is there anything that I can do to make sure that I don't get fibroids? Or is it just kind of like, hey, sis, it's in your genetic hereditary situation, so it's just destined to happen. It's just how big are they going to be?
Question for you. If you have a fibroid that's this big, is it going to freak you out?
Honestly?
Yes, right?
Yeah, because so in my case, I'm just thinking like that has it could possibly get bigger. So I'm like, I know you mentioned like, eating fruits and vegetables. Like, does drinking more water help keep the fibroids small or keep them away? Does exercising on a regular basis, does that help? Like, are there things that I can be doing now to make sure that if it is this big, it doesn't occur? Or if I don't have any, that they just won't pop up at all?
The reason why I asked that question is because they're so concerning. And I have yet to meet a patient that would say, I'm not concerned if I have a small tumor. If it's a tumor, you're concerned. So that concern should translate into being evaluated. I honestly feel that if you have a family history, a significant family history of uterine fibroids, your menstrual cycle needs to be evaluated and potentially an ultrasound performed so that you can at least know where you are. So for example, Jackie, you say, well, everyone in my family has this history of having fibroids. They had surgery. I don't want to have all this stuff happen to me. I wonder what's my situation. You come in and say, well, tell me about your menstrual cycle. Well, I pass clots sometimes and, it's heavy sometimes. I wonder if you have fibroids. Perform an ultrasound on January 1st, 2021. Perform an ultrasound. Jackie, there's nothing there. Mm-hmm. Oh, great. Wonderful. So we'll just do, we'll manage this a little bit better with medication, whatever. We won't do anything at all. We'll do herbal. We'll do whatever to get your bleeding under control. But you come in 5 years later and you're like, doc, this is still going on. I do an ultrasound and lo and behold, I see a small fibroid. Now we know how to manage that fibroid. We can watch the growth over time, and we know when we need to intervene. Mm-hmm. The important thing is to determine what your baseline is and then go from there. If you have a significant family history, I think you probably need to be evaluated and just have a baseline ultrasound performed.
Okay, Jackie, when we're going to see you in the office? That's all I got to say.
And literally, I think that is what I have been trying to, I'm afraid, and just being completely honest and open, I have been afraid of this topic. And I think I'm afraid, just like a lot of people do, of hearing that it may be something that I may have to deal with. But I need to just, knowing that I have a family history of it, I need to be more vocal and say like, hey, you know what? I need to, the next time I go to the doctor, like, can you check? Like, can we just keep an eye on this just to make sure that I'm good? I've been trying to duck and dodge the topic and the reality of it.
It's time.
It is.
That ducking and dodging, Jackie, is what I hear a lot of. And during that ducking and dodging period, if there is a fibroid there, it's growing. Yeah. It's changing.
You're right.
I'd much rather see you early on so we can jump in and slow that growth down so you don't have to have a hysterectomy or you don't have to have heavy bleeding as opposed to seeing you 3 years later. And what studies have shown is that women typically come in 3 years after they were initially diagnosed for treatment. Mm-hmm. And by that time, we have to do some pretty aggressive stuff. Yeah. So if we can find out early on, just because you have a family history and is this big, we can intervene and make sure that you don't need to have.
I think that's a really great point that you make, because I never knew that it's something that I should talk about early on. Mm-hmm. I always thought when you start having the symptoms, when you start having issues, that's when you need to say something. So to know that, forget all of that. No, say something early on to make sure that it's something that can be, evaluated and managed and overseen. Like that's great information for me, because, and I feel like a lot of women deal with that. We don't know to have these conversations early on. It's just like, wait until things get worse and get bad. And then that's when we need to say something. So I'm very happy that you pointed that out. Like, hey, just go say something now. Even if there's nothing there, it's better to get the no than find out like, oh, I have a fibroid the size of a lemon. Like that's not,
I think too, Jackie, well, once you know you have a health condition or you're at risk for it, you start to act differently in your life. Like you got to it's your body. You got to take care of her. So what are you going to do in your life to make sure? We already talked about fruits and vegetables. We talked about avoiding red meats. We talked about exercise and lifestyle. Well, doing those things aren't going to hurt any other part of you. So it just makes sense. It benefits the entire body, not just the uterus.
Yeah. When I tell you this has been so like, my nerves were here. And I told you, nerves were here. And now they're here. I told you I was going to go from here to here. And that's exactly what's happened. And I personally took something a lot away from this. I think the biggest thing at this point is I just need to get in and get evaluated to make sure that I'm okay. Whether there is a tumor, whether there's not a fibroid, like either way, I need to know. So that I can pivot and maneuver my life the way that I need to maneuver my life. And then just make sure that, I continue to live a great and healty life. And the only way I'm going to be able to do that is if I open my mouth and say something. So absolutely. Huge takeaway for me, because like I said, I was just like, well, yeah, I ain't dealing with nothing now. So I don't need to. That doesn't necessarily mean I don't need to open my mouth. So Dr. Walton, Dr. Stitt, thank you when I tell you so much.
No, thank you.
Thank you. This, I know everybody watching has taken a lot away from today, but personally, thank you, because I have taken a lot away from today. This is something that is near and dear. It's something that I have personally experienced with my mom, my grandmother, and my best friend. So to just, really get this education and this information and this knowledge has literally been like a godsend for me. So thank you so much today. Thank you.
It's been our pleasure.
I so appreciate you. If somebody wants to reach out to you individually to get more details, where can they reach out to you at?
Yeah, well, so the information is scrolling on the bottom, but they can also call us at 240-677-3000. Am I right? There's information on the website, but stay tuned because we are putting together all of the pieces that in our expertise, our radiologists, our maternal fetal medicine, our nutrition, and we're coming up with this comprehensive fibroid center that we're going to announce and launch very, very soon. Dr. Stitt is already doing the work, but we're ready to take this really head on from the front and the back end to help everyone in the county and beyond.
Absolutely love it. Thank you two so very much again. You have been amazing. DMV, thank you for joining me for another session of Girl Talk Live. Have a great evening.
Thank you.
Thank you. Bye.